CGTN, China Global Television Network.
The Center for Disease Control classifies Ebola as one of the deadliest viruses known to man. The largest reported epidemic occurred between 2014 and 2016 in West Africa, and it ended with more than 28,000 cases and over 11,000 deaths. The Democratic Republic of Congo declared a new Ebola outbreak in August of 2018 in the northeastern part of the country, and the epidemic has continued to spread. Earlier this month, it was confirmed that it had been carried over into neighboring Uganda, where 3 people died last week. Kenya and Tanzania have no confirmed cases so far, but are on high alert. This week, we ask if Africa is adequately prepared to deal with such large-scale health emergencies. And now that the World Health Organization has declared that the outbreak does not constitute a public health emergency of international concern, what exactly does this mean for the DRC and the rest of Africa? I'm Beatrice Marshall. Welcome to Talk Africa.
The DRC government announced the current Ebola outbreak in August last year, just days after another outbreak was declared over in the west of the country. This is the 10th and most severe outbreak in the country's history. According to the Health Ministry, more than 1,400 people have died since August last year. The disease has been raging in North Kivu and Ituri province in the northeast of the country. Global health organizations are working closely with the DRC government to contain the outbreak in an unstable area.
We have a very strong team on the ground working with our Ministry of Health colleagues. What's really set us back has been just hugely intense bouts of violence and insecurity. You can't stop Ebola when you stop for a week. And our operations shut down in a few hours, and they take a week or 10 days to bring back online.
The UN and international agencies have since strengthened their operational support in a bid to combat the outbreak.
So altogether, the UN will coordinate itself to create this enabling environment dealing with security, with political engagement, community engagement, humanitarian action outside Ebola in these affected health areas.
Health workers battling the outbreak have been attacked by armed groups and some community members who don't believe the disease exists. The WHO has recorded 174 attacks on health workers and facilities in North Kivu province. In April this year, medical charity Doctors Without Borders shut down 2 of its treatment centers after they were attacked by armed assailants. The response to the outbreak has also been set back by inadequate funds. The WHO recently expressed its disappointment with the international community for not fulfilling its promise of providing more assistance. The global body made an appeal for $98 million, but says it has only received $44 million. Health experts from the WHO had a meeting on the 14th of June to decide whether the Ebola outbreak was a public health emergency of international concern after the disease spread to neighboring Uganda. But they decided against making the declaration.
The current Ebola outbreak in DRC does not constitute a public health emergency of international concern. Although the outbreak does not at this time pose a global health threat, I want to emphasize that for the affected families and communities, this outbreak is very much an emergency.
The declaration would have led to the mobilization of more funds and a coordinated international response. But the committee said the threat of the disease spreading globally was still low. The experts also expressed concern about the negative consequences that would arise from the declaration, particularly trade and travel restrictions that countries would impose on the DRC, which they feared would affect the country's economy. The World Bank has so far provided most of the funding for the Ebola outbreak. International health agencies say they will continue mobilizing global and regional support to control the Ebola outbreak in the DRC in spite of the WHO's decision not to declare it an international health emergency. The UN and the DRC government have also committed to step up the protection of health workers and civilians in the Ebola hotspots in the east. Chris Ochamringa, CGTN, Kinshasa, Democratic Republic of Congo.
And joining me now to discuss this latest Ebola outbreak from Kampala, Irene Nakasiita. She's the Coordinator, Communications and Public Relations at the Uganda RedCross Society. In Nairobi, Peterson Wachira, Team Leader, Ebola Warriors Kenya. And Peterson was also a part of the team of health workers deployed to Sierra Leone during the 2014 Ebola outbreak. We also have Dr. Ngoy Nsenga, Team Leader, World Health Organization Emergency Program in East and Southern Africa. To you all, thank you and welcome to Talk Africa. Dr. Nsenga, let me start off with you because you have been recently in the DR Congo. DRC declared their 10th outbreak of Ebola in 40 years on August 1st, 2018. By far, it is the country's largest ever Ebola outbreak. And just to look at the numbers there, currently there are 2,148 total cases, 2,054 confirmed cases, 1,440 deaths. Yet the World Health Organization has declared that this does not constitute an international public health emergency. Why is that?
Thank you very much. I mean, the declaration of public health emergency of international concern is led through a process. And that process, it has to be a decision taken by what we call emergency committee. That committee would guide or provide advice our Director General whether to declare a public health emergency of international concern or not, on the ground of very specific criteria. And let me add also that this committee actually is not people from within WHO. This is a committee from experts from all over the world. So they have a very independent view. It's not like a view from within WHO. So to declare a public health emergency committee, it has to be followed by several criteria, but I will just mention three ones. The first one is the risk to other countries, international spread. The second one, it has to be with the risk not only of international spread, but the risk of serious public health consequences to other countries than the country that is already affected. And the need for international coordinated action. So the committee thought this emergency right now, yes, it's an emergency, it's a serious situation in DRC, but in terms of public health emergency of international concern, it does not meet yet the criteria. So
let's look at your point, because you have just returned from Goma. You are in Kinshasa, but you've been in Goma previously. How is the situation? Paint the picture for us. We understand at least up to 20 infections are being reported daily. True.
I mean, we have gone to some where we have 20 cases sometimes, some days, reported by, daily. But if you look at the global pictures from where we were and where we are right now, first of all, you can see like in terms of number of cases per week, we are going a little bit down. That's one. Two, you could see that in some area that were previously affected, but now the outbreak is controlled. So it's true that the situation, I'm not painting here a very very nice, bright picture for what is going on in DRC, but it's a realistic picture, which means the colleagues are really working hard to try to contain this outbreak. And thank God, I would say, is because of the work that the colleague on the ground is doing, that the outbreak so far is still contained in Eastern DRC. So the outbreak is contained in Eastern DRC. Peterson, let me get your thoughts here, because you were a public health worker in West Africa during the worst crisis in 2014 to 2016. And that crisis started in Guinea and later on spread to Sierra Leone and Liberia. Compare for us when you see the response and the situation in the DRC with what you saw in West Africa.
You see, in 2014, we didn't have the lessons that we learned from the previous outbreaks. And now the countries that are bordering or in communication, whether via airports and wherever, are taking maximum precautions to ensure that this does not happen. So you remember in 2014, first everybody expected that it was going to be contained in Guinea. But then it is spread into Sierra Leone and Liberia. Ellen Johnson, that is the president for Liberia then, she had to actually lobby for it to become a public health emergency of international concern. So as the warriors, we are concerned that sometimes this is just within the course of the same. But now that we are praying that now that we have learned lessons from the 2014 outbreak, that we'll be able to contain this within now Congo and Uganda, and that it will not spread into the other countries.
Let's hear from Uganda, because we've had 2 cases now in Uganda. Irene, from your end, there have been 2 confirmed cases from Ebola in Uganda and several suspected cases. And we do know that there is a lot of cross-border travel and between relatives and other people, between the DRC and Uganda. What are Uganda's concerns at this point?
Thank you so much for having me. I just want to begin by correcting that there are not only 2 cases, but there were actually 3 cases that were confirmed in Uganda, and unfortunately all of them passed on. Apparently the cross-border travels are still happening, and well, the concerns are there, we can admit, but then the preparedness that we have had since last year in August is actually good enough and has enabled us to manage and contain the condition or the situation pretty fast, because apparently we do not have any other confirmed case in Uganda.
There is no confirmed. Yes, your thoughts?
Let me come back to your question earlier about the difference between West Africa and now in DRC. There is a huge difference between DRC and what happened in West Africa. We are now in DRC in the 10th month of the outbreak in DRC. But yet, this is the first 3 cases. And by the way, look at how these 3 cases were identified, detected, and quickly, swiftly taken into account. I mean, the management started swiftly in Uganda and in collaboration in terms of information sharing with DRC. These are the elements that at the beginning, at least, of the outbreak in West Africa, we did not have. By now, we could have been in not only 3, maybe 10, 14, or even 20 cases. Right. That's one. The second one is these 3 cases. As we're saying, Uganda was prepared. For the last 8 months, the neighboring countries are getting prepared and ready in case any case, Ebola case, cross the border, which at the beginning of the outbreak in West Africa, we did not have. So there is a huge difference in terms of strategic approach to the 2 outbreaks between West Africa and now the DRC outbreak.
Right. Irene, get your thoughts here. There is a huge difference between Uganda situation, the DRC situation, and West Africa now. But take us through, though, how Uganda has responded to the 3 cases that you've mentioned. What is the first line of response, and what actual other measures Uganda has put in place on the border, particularly to ensure that there is no further penetration of the outbreak?
For starters, I must say there was a lot of surveillance, and then the coordination between Congo and Uganda. Because for starters, these people had actually been communicated about to Uganda by the DRC team. So the surveillance began from there, and this enabled us to manage to track these people from wherever they were and then put them in hospital so that they are managed from there. Then, in terms of how we are managing or stopping the further spread of Ebola to other parts of the country, like I already mentioned, our preparedness began 10 months ago, and then the efforts are still continuing. 1, everybody who crosses by the border point, the main border points gazetted by the government, undergoes screening. But then the loophole we had, how the other 3 cases came in, they used a porous border point, which was not managed, and there was no screening. What we are putting in place right now, the RedCross is managing the border points and also managing the screening. We are deploying now teams of trained volunteers at all those porous border points so that whoever enters the country shall now have to undergo screening as well. Then when people are in the communities, there is a daily risk communication plan. People have to be sensitized on a daily basis about Ebola,
Right.
and then the facts that they should know about Ebola, what they should prevent. But also we have ambulances in these communities which help us to track cases and also refer them just in case we have any suspected cases.
Right. Peterson, I do want to come back to you because you were in the front line in 2014 to 2016. What was it like for you on the front line?
So when we went into Sierra Leone, we found out that it was a very wanting situation. Actually, the country had come to a halt. There was no education. The economy had come to a halt. The health system had actually collapsed. But I think among the lessons that we learned is that you must tailor-make the responses to the communities that you are dealing with. Because most of the reasons as to why the spread was so fast was not because of the health system, but because of the health-seeking behavior and how socially people relate. Like in Sierra Leone, you'll find that in most communities, when you fall sick, everybody in your family will come placing their hand on your face. And by then, probably you're having the symptoms, you're contagious, your profuse is sweating, the wet symptoms. And that is how some families were wiped out completely.
All right, we'll stop it there for a moment and take a short break now on the program. But when we return, we will continue with our discussion on the Ebola alert in East Africa. Do stay with us.
China Global Television Network. From broadcast centers in Beijing, Washington, and Nairobi. A unique global perspective. 6 channels and a video content service. News when you want it and where you want it. On TV screens, websites, mobile platforms, and social media. CGTN. See the difference.
Welcome back to Talk Africa. Now, still with me, Irene, Nakasiita, Peterson Wachira, and Dr. Ngoy, Nsenga. And before the break, we looked at the current situation in respect to Ebola in East Africa. Let's now look at some challenges and possible solutions for containing the epidemic. Irene, when we look at the situation between the DRC and Uganda, we understand that the 3 cases that succumbed to death in Uganda had actually crossed the border to attend a funeral in an Ebola area. How are you addressing this kind of cultural issue between the relatives in the DRC and Uganda to contain the problem?
What I can say is in terms of coordinating with Congo, we have a task force that we are dealing with in the Congo, and then when we have cases that are crossing from Congo to Uganda, they are able to communicate to us so that that surveillance team can actually coordinate and manage these people. However, even with the cross-border business that happens on a daily basis, we are able to screen these people before they enter the country, and this is one way that we can mitigate cases from crossing from Congo to Uganda. Because now the lessons we've learned after having the 3 cases that crossed from Congo to Uganda and eventually they died, we actually saw that the porous borders were the problem. And because there was nobody managing the porous border or even screening people who were using the border points. So now we are installing screening points, rather screening gadgets at all the border points, including the small porous border points, so that everyone who enters is actually screened. So I think the coordination with DRC and then Uganda will actually be a very good method for us to manage cases that might cross from the one country to another.
Peterson, you did find a similar situation in West Africa regarding cultural norms there. How was that dealt with, though? How was that dealt with to overcome the stigma of lack of cultural practicing?
Yeah, actually, that was one of the biggest problems, and that is what led to increase in infections. And how it was dealt with was through social mobilization, using our communication department, where they were able to sensitize the public that actually what you are doing is not bad, but when it comes now to Ebola, you actually need to change this, because this is what is leading to these transmissions.
Right, Dr. Nsenga.
In Africa, there are some, I don't know if we call it behavior or social norm that is very difficult to go against. I mean, like the case from Uganda is the father, I think, who passed away the other side of the border. So it's very difficult to tell the family not to cross and go participate in whatever funeral the other side. But that's why in Ebola, the collaboration of the community, what we call community engagement, is very key. We cannot solve Ebola problem without community engagement. That's one. And I absolutely agree with Irene, the collaboration between the countries, not only at national level between high-level policy maker or decision maker, but also at district level. Those district, neighboring districts should be talking to each other, giving information to each other for early detection and early response and early action. That's very important.
Right, Dr. Nsenga, I want to ask all of you, though, these questions regarding collaboration with community and with governments as well, because you did write in your article that we also need to rethink our surveillance system in the African context. Risk analysis should be part of our surveillance system. Is Africa, though, prepared to deal with such emergencies if they occur, going by the lessons that we have learned from West Africa?
When I'm talking about surveillance, when you look at our surveillance in the context of Africa, how does it work? How is it working? As of today, we are catching up past event. What do I mean? It means we are looking at what happened yesterday in every district or every village. But in our context, especially like when you look at the eastern DRC, when will that isolated village, where even motorbike to go there is very difficult, when will they send the notification to the provincial capital or the district capital? Is very difficult. So it's good to anticipate by doing the risk analysis. If we know that this risk, this district, this village is at risk of Ebola, then we start preparing that village, that district, that county.
Does Africa, though, have the capability of the surveillance?
Absolutely.
But is it in place?
Absolutely. I mean, the surveillance is already in place and is working. Of course, Africa is not one continent, it's not one country, it's different from one country to country. There is what we call the IDSR, the Integrated Disease Surveillance System and Response, which is working perfectly. But we need to go beyond collecting the data of what passed yesterday, what happened yesterday, but to be more proactive. Of course, we need to reinforce the current disease surveillance system, but we need to go more proactive in analyzing the risk that our communities, our villages, our counties and districts are exposed to.
Irene, in terms of combining these efforts to fight the scourge, do you find that Africa, learning from the lessons of the past, do you find that Africa is now prepared to deal with such health emergencies, such as the Ebola outbreak now in DRC?
For East Africa, or for the countries that are already at stake, I can say yes. Because one, when you look at the preparedness mode most of us have been in when DRC Congo is struggling, I can say there's some capability, there's some capacity built over time. And then there are quite a number of lessons that people have learned and documented, which are helping us to improve on a daily basis. Because at least as Uganda watches what is happening in the DRC Congo, as Rwanda watches what is happening in DR Congo and Uganda, they are also able to pick lessons and fix the loose ends that they could be having right now. So the built capacities, yes, are helping us to be able to manage. And I know, well, it takes time, it's just a matter of time, but I'm sure there's some built capacity, although when it comes to resources, we really need a lot more resources to be able to help us manage and go through this situation.
Peterson, I need to get your thought on this because you were there when the health system in those 3 West African countries collapsed. Do you think something has been done? Do you think there's been a lot of improvement in the health sectors?
I think we're having a lot of improvement. I also know that the African Union is trying to put together an African CDC and a surveillance system that can be able to pick these early and eradicate. Also, I can talk about Kenya as an example because you see, we are not immediate neighbors to DRC Congo, but we are not leaving anything to chance, and our surveillance right now is top-notch. We are prepared even if we are to get a singular case. We are prepared, number one, that they don't transmit. And number two, that we actually ensure that that case does not become fatal.
Right. Irene, I noticed you smiled there, but you have been very optimistic about the processes that have led to the containment of the outbreak in Eastern DRC. Are you confident that the situation we saw in 2014 in West African countries will not happen in East Africa?
I really feel it can't really happen that much because, like I've been mentioning, the preparedness bit, one of my colleagues while we were beginning the interview said, yes, Uganda has been prepared for the last 10 months. So the preparedness that we are into or we have been in largely can actually help us to manage, because I don't think the situation can get to that worse as it happened in Sierra Leone. So right now, I know my brothers in Rwanda, because through coordination with the Rwanda RedCross Society, we are in touch. I know they are also equally prepared. So it's like I said, it's really just a matter of time, but any single case can actually be managed and contained if a country is really prepared. And we've really built the capacities, I can say, because most of us have at least teams that are able to at least manage or monitor a case and also refer, and the earlier we notice the signs and symptoms, the better. And then just in case of a death, because this is inevitable, there are teams that are trained at least to manage safe and dignified barriers, and they can actually stop the spread of the Ebola to other parts of the communities.
How should this Ebola in DRC be handled? Because Dr. Nsenga, you did mention that you're from the DR Congo, and this is the 10th outbreak so far. How should it be contained? How should it be handled?
Okay, for the DRC Congo, we have to start with why are we at this stage? Why are we where we are now? Mainly is because of the challenges that we are encountered in Eastern DRC, and one of the biggest challenges is security. And unfortunately, this is the area where health workers, they have little to do with security. I mean, they have to work with, they have to work around that issue. So that's the biggest. And fortunately, I think the UN system now has taken it up by even appointing a special representative of the Secretary General to address the security issue, because without reaching the people that we need to reach, it will be difficult. So that's one. And I want to add to what Irene was saying, is very unlikely from my point of view as well that what happened in West Africa can happen in East Africa. Not only countries are prepared, and all of us, all the organizations that are working on the ground have learned lessons, but also we have tools that we did not have in West Africa. For instance, we did not have vaccine in West Africa, which we have now currently. All
right, Irene, you have the final word on this.
I will speak from a communications point of view and say community engagement. You see, like one of my brothers, the panel discussants, was mentioning that in Africa we have so many common cultural practices, so many, and they're actually very synonymous. Many times when people die, we want to relate even with the dead. At least if somebody's sick, you even want to touch and feel the temperature, exposing ourselves to this. Sometimes even when their community is speaking to us or experts speaking to us, we want to first experience. Like when a child, you tell them, don't touch that fire. Some of them want to first touch, and when the fire burns them, that's when they know the reality. So the more we engage communities in this fight, I think will be another tool of helping us to fight this together. I have heard rumors from the DRC Congo that sometimes people do not want even to listen, even when they are sensitized. They think now this is beyond. They no longer want to appreciate or even accept that Ebola is real. So we need to strengthen the community engagement, the continued sensitizations, and the risk communications. Maybe the further we go, maybe these people can come to appreciate this. But like all my colleagues mentioned, the political atmosphere should be a little calm for us actors to be able to reach the people that we need to reach with the messages and all these efforts that we are putting in place to make sure that we fight Ebola together.
Irene, Nakasiita, thank you very much for your insights. We'll leave it there for the moment. That's all we have time for this week, but thank you to my guests, Irene Nakasiita, Coordinator, Communications and Public Relations, Uganda RedCross Society, Peterson Wachira, Team Leader, Ebola Warriors Kenya, and Dr. Ngoy Nsenga, Team Leader, World Health Organization Emergency Program in East and Southern Africa. Remember, we'd love to hear your feedback through our social media handles on Facebook and Twitter. You can also catch the show on our YouTube playlist. To keep the conversation going, and tune in again next week for more Talk Africa. From me, Beatrice Marshall, and the team in Nairobi, it's goodbye.